Hello everyone, my name is Marian. In today's video, I am going to do a presentation on the current radiological findings in breast ultrasound. So I do work as a breast ultrasound tech. I work in radiology. I perform x-rays, CTs, MRIs, mammography, and now breast ultrasound scans. So how I got into breast imaging, I was performing breast MRI exams. Patients would come in after they had a biopsy, and sometimes it was around the time they was just diagnosed with breast cancer. And they told me they had a clip in their breast, and I wasn't sure if it was safe or not because with MRI you have to make sure patients doesn't have metal, they doesn't have any implants, they can't go inside the MRI room. So as I was doing research, I just started getting interested in mammography and I joined mammography and then crossed over and trained in breast imaging or breast ultrasound. So that's how I landed as a breast MRI technologist. So for this outline for today, we're going to talk about an overview of breast ultrasound, the reason for a breast ultrasound scan. I'm going to discuss the risk factors for breast cancer, describe the correct positioning for patients whenever they are in breast ultrasound, discuss the BI-RADS score that is used in breast imaging, name the different types of borders and shapes that is seen on breast ultrasound, discuss different types of pathology that is seen in breast ultrasound, discuss breast ultrasound scans pathology seen in men, because there are times where men have to come in for a mammogram if they feel a lump or if they have pain that is just bothering them and it won't go away. And then I'm also going to describe the correct positioning for patients to visualize the pathology properly. So if you do not know what is a breast ultrasound, I will tell you in this section. Breast ultrasound is an imaging test that is going to use sound waves to get the image of the inside of a patient's breast. It does not use any form of radiation. And a breast ultrasound scan, it can be ordered as a screening ultrasound or a diagnostic ultrasound. So if a mass or abnormality is found on the ultrasound images, then the radiologist will probably recommend a follow-up scan, an ultrasound guided needle biopsy, or a fine needle aspiration will be recommended. Whenever it comes to ultrasound, ultrasound is promoted as a safe and non-invasive diagnostic test when it is compared with mammography, CT, X-ray, nuclear medicine, because ultrasound does not use any sound waves. However, there is a potential for ultrasound-induced thermal and mechanical tissue damage, and also that's why we want to make sure that we are checking the wires, checking the cables, making sure that the machine is functioning properly, performing the QA and the QC on the machine when needed. Now I'm going to talk about ALARA. So I started as an X-ray tech first with ART, and my previous instructors taught us all about ALARA. So ALARA is avoiding exposure to radiation that does not have a direct benefit to you, even if the radiation dose is small. So with ALARA, you have your time, distance, and shielding. So you want to reduce the time that you are scanning, increase your distance, and then you want to shield. So when it comes to ultrasound, we do not have to shield because it doesn't use radiation. You do not have to really worry about the distance because there's no radiation involved, but you do have to worry about your distance between you and your patient. You want to try to bring your patient as close to you as possible so that you aren't stretching over and causing injuries to your shoulder because we do not want to injure our shoulder. When it comes to time, you do not want to be in the ultrasound room scanning their breast for a long time because you may have a high chance of misdiagnosing a patient. So, as a technologist, if you don't know what you're looking at, go get the radiologist, go get another ultrasound tech. I know a radiologist trained me to do breast ultrasound They're very helpful. They will come in, they will show you how to scan, they would scan behind you to make sure you didn't miss anything if you're not comfortable, and they will also show you the pictures before you begin on how certain scans should be done or where you should be looking for a certain abnormality. You have your safety hazards with ultrasound, you have your diagnostic error. So, to reduce this, you want to use a well trained person who is doing the scans. You have your biological cross infection. Make sure that you are cleaning the machine, wiping it down before and after each patient. Allergic reaction. Check with the patient to make sure that they are not allergic to the ultrasound gel, if they are sensitive to latex, if they are sensitive to the transducer covers, any type of gloves that you will be wearing. Chemical hazard, use of appropriate transducer and cleaning and disinfecting the transducer and any other materials is required. Electrical, make sure that the cables and the coils and the wires is intact. It doesn't have any type of cuts or strips in the wires. And for acoustic, just make sure that you are minimizing that scan time and the contact with the transducer on the patient's breast. So this is a way we can promote safety in ultrasound. You want to make sure that you have someone properly trained that can know the anatomy, that can know the machine, where the buttons are located, and how to annotate the picture. You want to stay knowledgeable and informed on the latest technology changes. If you can see artifacts better on this machine versus that machine, if the pictures are coming out better, or maybe they're coming out worse, and you need to talk to your supervisor or manager about getting a new machine. Change in practice. Make sure that an application specialist come in and train new techs to use the machine so that they know how to use it and use it to their full ability. Sometimes you're training behind someone and they probably can't tell you all the ins and outs of the machine like an application specialist can. You want to choose and use appropriate equipment and technique. Know and understand your patient's allergies, contraindications, physical and mental limitations. For breast ultrasound, we have to get the patients to bring their arm up. So if I'm scanning their right breast, their arm have to go up above their head. Sometimes the scan is for 5 minutes, 10 minutes, 30 minutes. So you just never know. And then you want to make sure that your equipment has passed QA and QC. And make sure that you are following all the good practice to reduce injuries, whether it's verifying that you have the correct patient, the correct order, and the correct procedure is being done. So now I'm going to get into the purpose of breast ultrasound scans. This is going to talk about screening, diagnostic, pregnancy, pathology, and biopsies if needed. Now we're going to talk about why did the doctor order a breast ultrasound scan. I always like to verify this with the patient because sometimes they come in and they don't know why the doctor ordered it. So a breast ultrasound scan may be ordered if an abnormality was seen on a mammogram image, on a previous breast ultrasound scan, or if a lump was felt. Sometimes it's used of course whenever a patient come in and they have pain. So if they had a mammogram and it was normal, but the patient just want the breast ultrasound and they don't want to take the radiologist's word and they just want to know what is causing the pain. Sometimes them having that breast ultrasound will give them some type of reassurance that nothing is wrong because you have patients who maybe have met their deductible or do not, mind paying the ultrasound bill if they have to. So sometimes they just want that breast ultrasound scan done just to give them peace of mind. And then you also have that it is helpful for patients with dense breast tissue. If a patient is pregnant and they have a palpable lump, which is a lump they can feel, then the radiologist may suggest for the patient to start with breast ultrasound. That's why we always just check with the patient or the radiologist first to make sure that, hey, the patient is this age, they said they're pregnant. So would you like for us to do a mammogram first or breast ultrasound? And then this scan can be done and performed on patients younger than 25 years old. With the risk with breast ultrasound, it doesn't have any risk from radiation because it doesn't use radiation. Therefore, it does not pose any risk to pregnant women. It may or could miss palpable lumps or solid tumors that are commonly found with mammography. If you have a patient that is obese or have a patient that has very large breasts, then it may not provide as accurate ultrasound results. And then companies need to make sure that their technologist is licensed or properly trained to perform the breast ultrasound scan. This is a breast ultrasound transducer. This is how we take an image of the breast. And then the flat part of the transducer or the probe where you see the arrow pointing up to, that's where we apply the ultrasound gel. And then this is just another picture of a transducer that we're using with breast ultrasounds to look at cysts, fibroadenomas, any type of tumors or lesions like cancer in the breast. And we also look under the patient's arm as well to get a picture of the lymph nodes when needed. This is a hockey stick, we call it. This can look for those superficial small structures, ducts, small cysts, or mass that is close to the nipple or behind the nipple. We also use this for the axillary or axillary region as well. So before I start a breast ultrasound scan, and if you are a tech and just watching this for like a refresher, then I always refresh my work list first. Make sure that you review prior mammogram images and or breast ultrasound images, and then make sure that you have the correct patient, that you are performing the correct exam, you have the correct breast. Make sure that you know if you are selecting the wrong patient and scanning the wrong side, this will delay the patient's results and treatment planning. So make sure that you have the correct patient pulled up because the wrong patient will get that patient results and then the correct patient won't get the correct results. So therefore, they're going to get the wrong treatment and maybe get the wrong surgery if surgery is required. Okay, here you have an example of a breast ultrasound machine. You can pull up your patient. You have your probe you can select, the image you can view. You can review the images. You can see the report. You can end the exam. It also has a button for to refresh the screen. You can also see that you have a gel warmer. So now I'm going to go over the risk factors for breast cancer. This is just going to be brief, talk about the major and the minor risk factors. For your major risk factors, these are things that you cannot control. Number one, being a female. You also have age. Older patients have a higher risk of getting breast cancer, although younger patients are diagnosed with it too. Your genetic risk factors, such as your BRCA1, BRCA2 gene mutation, family history of breast cancer, whether it's your mother, sister, paternal or maternal grandmother or aunt, and then a history or family history of ovarian cancer. If you have dense breast tissue, personal history of breast cancer, atypical hyperplasia breast biopsies. For your minor risk factors for breast cancer, you have not given birth, having a first child when older than 30, if you did not or could not breastfeed, less than 12 years of age if you had an early menstrual cycle, if you had a late menopause, if you was taking hormone replacement therapy medication, weight gain, not exercising, consuming alcohol, being a smoker. This is just an example of whenever I am charting, we always ask the patients to put in all this information, their menstrual cycle, hysterectomy, how many kids did they have, when did they have their first child, do they have a family history of breast cancer. This brings up a TC life score at the bottom. Anything above 20%, we always tell the patient you may get a call from the high risk clinic, and then they'll just talk to the patient about probably alternating between a mammogram and breast MRI or having a breast ultrasound done yearly for screening purposes. The patient positioning with breast ultrasound is very important, so I will dive into this. For communication, you want to make sure that you are communicating with the patient, making sure that you have the correct patient, the correct exam pulled up, Knowing their clinical history, if the lump or if the pain was, how long did it take? Was it there for a long time? Has it been there for a month? Is the lump that they are experiencing hard? Can it move? Um, is it big? Is it small? Different things like that will help the radiologist out a lot. So you always want to just document these notes. And even the technologists that could be performing the scan for the next year, they will get an idea of where this area is located at. And then this is just an example of how you can chart if you are using computer, and then you may recognize this charting system. So if you do, put it in the comments if you use this. So if a patient come in, you can just put if they have a lump or a pain, and you can put it at which area of the breast they're feeling this. And then for the symptoms, is the lump found on the right breast, on the left breast? If it's found in their axilla, different things like this. You just want to make sure that you are charting correctly and accurately. If they've had prior biopsies, which side was it on? Left side, right side? Did they have a breast lift? Did they have breast reduction surgery? Do they have breast implants? If they've had cancer before, did they have a lumpectomy? Did they have radiation with it? Did they take chemotherapy with it? For your clinical indication, so this is going to be first line breast imaging investigation for women under 35, women with breast implants, pregnant and lactating women, men suspected abscess, open infection, symptoms related to the axilla. And then this is normally performed in conjunction with mammography if it is a focal palpable mass, further evaluation of something that was seen on their mammogram, or if a biopsy or aspiration is needed. And then you also can put in, if a patient comes in, we're doing this scan because they felt a lump or their doctor felt a lump, or maybe just a follow-up exam. For clinical indication, breast ultrasound is not routinely indicated when patients are in for pain, although some facilities or radiologists, they'll look at the mammogram or the recent mammogram. If a patient had a mammogram, let's say in March, and then they're back in May, then they'll let the patient have the scan of their breast, and then you'll just target it to the certain area that the patient is feeling. And then most of the time, if a patient come in for a diagnostic mammogram and the mammogram looks great, then they'll tell the patient everything looks normal on your mammogram. You're having pain due to maybe your bra, maybe caffeine. Try to change your bra, reduce the amount of caffeine intake. It could be hormonal. It's certain different reasons. So then you also have, if a patient come in with several lumps, then it's normally not routinely performed if a patient has several lumps all over their breast. So, and then you can't just perform it for fun. So just make sure that you're not in there just scanning your breast just because you want to do it. And then if a patient come in for pain, this is just how I would annotate. When you're scanning the entire breast, then sometimes we call it like a complete breast ultrasound. This can be for suspected silicone implant leakage, high-risk patients due to breast density or scarring from previous surgery. Sometimes I've seen patients come in for a screening mammogram and maybe they're high risk or they have a personal history of breast cancer, so they come in for a complete bilateral ultrasound. Whenever we are preparing the patient, we have to remove everything from the waist up. They cannot have deodorant or lotion under their arm, because sometimes, even though we're looking at the breast, we take a look at under their arm as well. That's where lymph nodes are. They cannot have any type of piercings on their nipple. And then we also keep the bed rails up if we're stepping away to show the radiologist the scan. And then a patient will be lying on their back. We do put a pillow or a wedge or some type of towel behind them to just kind of prop them up at an angle. We do get their arm above their head, depending on what breast we're scanning. And the patient's normally on their back or they're kind of tilted at an angle. And then we also have them in like an oblique position, which is like a 30 to 45-degree angle. If a patient cannot tolerate a certain amount of positioning, then I always put in notes the patient can tolerate the positioning, or if it's in mammogram, they couldn't tolerate the full amount of compression. And then just know your limits whenever it's coming to maybe the patient can't position correctly, or if you feel as if you're not getting a certain area in the breast in there, or you can't find that lesion, don't stay in the ultrasound room for a long time. Just go talk to the radiologist. Let them know that you're having trouble finding that abnormality. When you're scanning, you want to make sure that you're upright. Use your wrist. Don't extend your arm up high. Keep it low. Keep your arm lower than your shoulder to avoid injuries. Now, we do hold the probe to do the scan, and it's a certain way you have to hold it so that you do not injure your hand or your wrist. Scan with your wrist, turn your wrist. And this is just like a background of ultrasound, just so you know kind of like the history of it, because in a moment I'm going to cover the lesions. For the breast anatomy, we like to have the skin, the fat, fibroglandular breast tissue, retromammary fat, the pectoralis muscle, the ribs, the lungs, the pleural cavity. This is an image of the axilla or axilla. You can see that the blue arrow is pointing to the lymph nodes. There are times where we do have the image under their arm, especially if some type of abnormality was seen on the breast, or it could be suspicious for breast cancer, or maybe it was breast cancer that was found. And we're just checking their underarm to make sure a cancer have not spread it to their lymph nodes. And then whenever we do scan, we can adjust how much of the breast tissue we're scanning. We can adjust the what we call the field of view so that we can get a good picture of the lesion or the cyst or the tumor that was found. And this is just another picture of the monitor or the ultrasound machine that I was using. You have different buttons on here where you can measure, you can annotate different words on there, kind of like patient is having pain, patient feel a lump, which breast you're scanning, how many centimeters from the nipple it is, which breast position it's in, whether it's 12 o'clock, 3 o'clock, 6 o'clock. Because when we're looking at the breast and scanning the breast, we think of it at like a clock face, so we use like 12, 1, 2, 3, all the way back to 12. We use those numbers when scanning. And then just more images of the machine that I'm using or was using. So we like to be careful not to measure ribs whenever we are scanning. I know as a new technology, it can be easy to mistakenly measure ribs, thinking that it is some type of pathology. So that's why it is important to know your anatomy. And then there are different ways you can scan. You can scan longitudinal, you can scan transverse. Um, some people scan radial, anti-radial. And this is where I'm just talking about here, where it just go over what radial is, what anti-radial is. And this is an example of whenever you're scanning sagittal versus transverse, or anti-radial versus radial. Now let's talk about the BI-RADS score. So in breast imaging, the BI-RADS score is pretty much what the radiologists use to score or to read the images. Whenever they have a finding on there, there are numbers where they say, okay, number 0, that means the patient need to come back in. It goes all the way down to number 6, and I will get into the BI-RADS score right now. So before the score comes, we like to put why a patient came back. So maybe they came back to evaluate a lump. Something was seen on their previous mammogram. Now with the BI-RADS score, if it is a 0, that means the patient need to come back because that test is incomplete. maybe something was found and the patient just need to come back just to make sure that it's nothing bad, or maybe it's something benign and they just want to let the patient know, follow up on it, or you can go back to your screening mammograms. If it's negative, that's a normal test. If it's benign, then that's the test is negative for findings that are found as benign. You know, those calcification, masses, or lymph nodes in the breast, probably benign. The radiologist will recommend for the patient to come back within 6 to 12 months. If it's a suspicious abnormality, a biopsy should be considered. If it's highly suggestive of malignancies, then the findings look like cancer. A biopsy is strongly recommended. You also have a non-biopsy proven malignancy, meaning that a biopsy confirmed a cancer. So at this point, the patient will be given like a treatment plan and when to have or what type of next imaging they have to have done. Now we're going to talk about clock positions and quadrants because in a moment we'll be getting into the abnormalities. So all of this is going to just build up to how we scan, how we get the correct picture to see those cysts, to see those fibro abnormalities. So you have to kind of see this first before you can see, oh, how did they find this cyst, or what made them get this position. So with annotation, we like to put what breast we're looking at, whether it's right breast, left breast, 12 o'clock, 3 o'clock, maybe 7 o'clock. How many centimeters this is found from the nipple. And then this is just an example where you can put which breast you're looking at, like different wording for it. Okay. And then in breast imaging, we use quadrants. So we have upper outer quadrant, upper inner quadrant, lower outer quadrant, lower inner quadrant. So most cancers are found in the upper outer quadrant. And then this is another image whenever patients come in. The radiologist report may say something was found on the right or the left breast at 3 o'clock, 6 centimeters from the nipple. So that's why you're always supposed to review the prior images to know where was it found, kind of get an idea of what you're looking for, how big or how small it is. More charting is very important to chart, especially whenever someone is coming in. And because you don't want to forget important information, especially this can be helpful for another technologist for next year, or maybe it's helpful for the radiologist. Now the shapes and borders, you have circumscribed, which is mostly benign. You have your cysts and your fibroadenomas. And then these are other margins that we normally see on breast imaging, whether it's mammogram or breast ultrasound. If you do have something that's spiculated at the bottom, then most breast cancers will have this margin. And then these are the common shapes. You have your round shape, which is benign, meaning it's not going to be breast cancer. It's your fibroadenoma, it's your cyst. And then you have the circular or oval shape. It will be a benign mass, fibroadenoma, or cyst. If it is irregular like this and uneven in shape, then a biopsy is highly recommended just to make sure that it is not cancerous because it can be suspicious for a breast cancer. So with the borders in mammography or breast ultrasound, we like to make sure that we are measuring correctly. If a patient is in mammography, then you use magnifications or spot compression to just make sure that you can see the borders and the lesions correctly. And then we have key terms we use. We have anechoic, meaning the cyst or whatever lesion we found is black. Hyperechoic, is bright. So you have your bone, your ribs, your pectoralis muscle. Hypoechoic, the tissue is dense. So it may look dark gray on ultrasound. If I'm going too fast, you can always pause it, rewind it. You can watch as many times as you want to. This is just an overview of breast ultrasound and the lesions that we find. And indications for a cyst, you have anechoic, oval or round shape. Circumscribed is going to be horizontal. You're going to see that white part, or what we call posterior enhancement, no calcifications. So this is how a cyst is going to look in the breast. And then you have an image of glandular tissue, how this looks. So this is an image of a breast ultrasound right here. And see, all of the breast tissue, especially on the ultrasound, it may look the same. That's why we always put which area of the breast we're looking in. More pathology we're going to talk about. You have your breast cysts. This is pretty common in women patients that most likely will come in if they feel a lump. Sometimes patients have pain with this. And then you have how a cyst is looking on a mammogram and how it looks on breast ultrasound. The arrows are pointing to that white part that I was telling you about, and that round or oval cyst looks dark or anechoic, or look black or anechoic. Right here you have another form of a cyst. This is kind of considered like a complex cyst because you see that the blue arrow is pointing to what is like a split or septated in the cyst. So the radiologist will recommend a short-term follow-up, or may even recommend an ultrasound guided biopsy. And then you just chart patient came back because this is a 6-month follow-up. With medical, especially in radiology, charting is very important. Color Doppler, whenever a patient come in for either a cyst or a lesion, us as ultrasound techs, we like to put color on the image so it will help determine if something is a cyst versus a solid tumor. So if a color is in that abnormality, then it could be like a solid tumor, and it can help rule out if it's a cyst versus a tumor. And then you have another image of a cyst right here. Galactocele, this is like milk filled retention cyst, and it does develop in pregnancy. So this is how this would look. The findings would be like a milky fluid. And then you have your fibroadenoma, which is very common. So a biopsy is recommended to confirm whether it is benign or malignant. A lot of patients feel this as a lump. And then you have another picture of a fibroadenoma. Now for breast cancer, it is going to have a lot going with this. So it's going to be hypoechoic. The shape is going to be irregular. And then you're going to see the margin will not be circumscribed. So you will see some speculation, angular margins. It's going to go up taller than horizontally. So when it's horizontally, it's probably most likely benign. But when you start seeing it go up and start spreading, then it can be highly suspicious for breast cancer. So that would be that vertical orientation if you start seeing it go different ways. This is an image of mastitis, which is inflammation and infection in the breast. Trauma, whenever patients are in a car wreck, or if they fell, or if someone accidentally bumped them or hit them in the breast, maybe a pet jumped on them or kids, then they can have different trauma in their breast, like a hematoma, seroma. So most of the time they'll probably come in for a breast ultrasound if they decide to come back. Sometimes patients have this bruise, or they may decide not to follow up because they think it will go away. But if they do come in, then it will start forming as like fat necrosis. We do scan male patients, so I will go over the breast disease for them. This is an example of the male breast anatomy compared to a female breast anatomy. This is how their breast will look on the image. For male breast, it's going to probably be one of these for benign disease: gynecomastia. You have lipoma, mastitis, a sebaceous cyst, fat necrosis. Whenever we do perform a mammogram on male patients, it's done exactly how we would do it for women patients. They are in the same position. They tolerate the same amount of squeeze, if not sometimes less or sometimes more. But it is done like how we do women mammogram images. And then this is just an image of gynecomastia, lipoma. This is how a lipoma will look. And then you have your cysts in males. And then on the picture, you see how it's annotated where you have right breast, 12 o'clock, 4 centimeters from the nipple. This is how breast cancer in male patients will look, very similar to how women breast tissue look. And then these are all the risk factors for male patients, which is slightly different from what female patients' risk factors are, although there are still similarities. So the key takeaway from this video, if you made it this far, give it a thumbs up. Let me know in the comments how you enjoyed this video. Or let me know in the comments if you work in radiology, if you were just interested in the topic, if you are an ultrasound tech. So just to take away from this presentation, just a quick summary. It's always good to document. This can help the technologists that is doing their scan in the future. This will help the radiologists. This is just showing you how educating your patients to come back in to follow up on these abnormalities or to just follow up in general just for their screening mammogram to detect abnormalities like this, because some patients think whatever is found in their breast is cancer. So sometimes they don't want to follow up with it. Sometimes they do want to follow up with it. Even if they come in, they may or may not be nervous. It could be their first time. So we always like to reassure our patients you're doing the right thing just by coming in, getting the scan. These are my resources, what I use to get this information. A lot of the images was found online, so I did try to notate where each image came from just to give them courtesy. Other than that, this is the end of this presentation. Please give it a thumbs up if you enjoyed it. Thank you all for watching.